This individual had addiction and attention deficit hyperactivity disorder. Now, ADHD that's untreated will present with many cognitive deficits. The brain is not stimulated enough to work properly. So, look at this terrible performance. Was it because of the ADHD or the addiction or both? Now, the only way to really tease it apart is if we withheld treatment for one of these illnesses, only treated the other one, and then retested. But that's unethical. As soon as we recognize an illness, we've got to treat it. So we treated him for both the addiction and the ADHD at the same time. Now, we saw improvement within a month later. We don't know if it's because we treated one, the other, or both, but sometimes we just have to accept that because we got him better. This was a patient with schizophrenia and addiction. You see very low across the board. Now the reaction time was above average, but the reaction time, it turns out, just tests one's ability to type a key very quickly. Yeah. And so you can imagine that you could have the capacity to do that, but perform poorly on the other cognitive functions. That was him 2 months later, starting to improve. You saw him move into the average range with regard to executive function. That's huge. In fact, I'd say, probably verbal memory and executive function are the two most important cognitive functions. This was a woman with schizophrenia alone, no addiction, on presentation. Oh, and by the way, she was someone who had she had completed 2 years of college at the University of Florida. She developed a psychosis. She was diagnosed with schizophrenia. She was treated with medicine. She had a complication with the medicine that she was beginning to respond to. So they had to change the medicine. She didn't respond. Tried another medicine. She didn't respond. They gave up on her and they sent her to a state hospital, expecting her to be there for the rest of her life. Her mother, fortunately, said, "No, I'm not going to tolerate that." And somehow she found us. So she drove up to the state hospital, forced them to discharge her to her care, and she drove her to us. This is how she presented. She was thoroughly psychotic at the time. She was 21 years old. This was 2 months later. Now, during that time, we had initiated the same medicine that had gotten her well, that she had the terrible effect from. Now, it turned out that she had a cardiac arrhythmia, which was a rare but possible side effect to the medicine that some of you know about, and I'm going to tell you more about later, and it's called clozapine. It's the most effective antipsychotic medicine, so it wasn't a surprise that she had responded to it the first time, and I was determined to get her back on that medicine. So I sent her to a cardiologist, and I told him the story, and I said, this is her only hope. It's either this or the state hospital. We're going to make this work. You'll deal with her heart, I'll deal with her brain. And we did, and we got her to stay on it. Before I get to this, I'll say, that was November 2013. She left us, I think, about May 2014. Before she left us, she had re-enrolled in school at Palm Beach State and was getting A's in every course, was 100% asymptomatic, no symptoms whatsoever of her schizophrenia. Nobody even believed she had it. She did beautifully on the medicine. Her heart remained fine. She left us, went to school full-time to finish. She came back 2 months ago just to show us all how she was doing. She was in a master's program. She was doing beautifully. She had friends. She was asymptomatic. It was a real miracle. It was great to see. She had been sent off to the state hospital. I was so disappointed in the University of Florida. So not everybody presents with severe cognitive deficits on admission with addiction. I'm sorry it's a little shady, but we couldn't make it better. This was a 17-year-old female adolescent, came into our program, brought in by her mother. She had become increasingly defiant. She was dropping out of school, the typical behaviors that indicate substance use. It turned out that she was inhaling 2 cans of hairspray every single day for the past year before admission. Severely toxic to the brain. Above average across the board. Remember I used that word resiliency before? This is an example of that. Despite being exposed to this toxic substance on a daily basis, it would not change her brain. She was resilient to the effects. Of course, I didn't tell her that. All right, what about treatment? Well, we break it down between medicine and psychotherapy. There are multiple examples of the kinds of medicines that we use to treat addiction. But to be fair, there's not an actual medicine that treats addiction, but the components of addiction. So we use it as part of the overall treatment plan, as part of the overall process. So we're providing multiple interventions simultaneously, medicine being one of them. So in nicotine use disorder, for example, we found quite a while ago that that substance that drives the use of nicotine is nicotine itself. You know, that individual who is smoking 2 to 3 packs a day. Nothing else in the cigarette but the nicotine that is driving that behavior. Now, nicotine really isn't harmful. If you use too much of it, it might race your heart, but it doesn't do all the damage to the body. It's everything else in the cigarette. The cigarette smoke, the carcinogens, the carbon monoxide, the tar, all that stuff wreaks havoc on the body. Nicotine, not at all. So suppose we just provide the nicotine without all the bad stuff. Could we get the patient to quit smoking? And that's the idea behind nicotine replacement. One of the reasons that the nicotine in a cigarette is so effective at creating dependence is because of how rapidly it gets to the brain. That's the formulation. Smoking the cigarette gets that nicotine absorbed in the lung, which shoots up to the brain instantly. Across the board for any substance, the faster you get it into the brain, right, stimulating that ventral tegmentum to release dopamine in the nucleus accumbens, the more likely it is to bring about that the high that the patient is attempting to experience. So of all of the different ways of getting nicotine to the brain, it's been determined that the most effective is the combination of the patch and the lozenge. That is, if you can maintain the same level of nicotine in the brain that the cigarette provides at all times, you decrease the likelihood of the nicotine level coming down, which, by the way, is what creates craving. Right? When someone's craving a cigarette, and any smokers brave enough to raise your hand? Thank you. And we're going to get you to quit before the end of the weekend. If you have enough nicotine in your brain, you're not experiencing any craving. As soon as you begin to experience craving, it means that the nicotine level in your brain has dropped, begun to drop. And you want to replace that level as quickly as possible. So you go out and smoke, and it replaces it. So if we can do it with something healthier, so you get the idea. Wellbutrin is an antidepressant, was developed as an antidepressant in the early 90s, and we all started recognizing that in our patients taking Wellbutrin, if they came in smoking, they started telling us that they had less of a desire to smoke. And could it be the Wellbutrin? No other antidepressant had done this. So then the pharmaceutical companies jumped on it and did studies, and sure enough, they were able to show that it led to a significant difference between those people using Wellbutrin, those people using placebo, there was a big difference in the amount that they smoked. And so then it became available to use in smokers, but they wanted to rebrand it as Zyban because at the time they felt that Wellbutrin carried a stigma. People wouldn't want to be taking a prescription that was associated with that psychiatric illness called depression. Same molecule. And by the way, it works in people who smoke who don't suffer from depression. You don't have to suffer from depression to benefit. There's a relatively small percentage of people who respond, but it's still better than placebo. Chantix, on the other hand, has a completely different mechanism. The reason nicotine has any effect on the brain is because there are nicotine receptors, responsible for many things, but also including cognitive function, nicotine receptors. In fact, some research has begun to show that because we see that our patients with schizophrenia have a very high incidence of smoking cigarettes. In fact, the studies show that about 20% of Americans smoke cigarettes across the board. It's been a drop over the years, about 20% now. you know, when I first read that, I was living in Manhattan, and I wanted to kind of test it out myself. So just walking down the street, you pass a lot of people in Manhattan, and a lot of smokers. I would count the first 20 people that I would pass and see how many of them were smoking cigarettes. And sure enough, it was about 20% on average, no matter what street or avenue I was on. So it turns out that some people with schizophrenia have an abnormal nicotine receptor. It's not working as efficiently. So one of the developing hypotheses is that what's driving that person with schizophrenia to smoke so much, and it's anywhere between 60 and 80% of people with schizophrenia smoking regularly, is an attempt to compensate for that faulty nicotine receptor, which affects cognitive function. And certainly I already told you that our patients with schizophrenia suffer severe cognitive deficits, and maybe the nicotine receptor has something to do with it. Now, in addition to that, there are a number of companies doing research looking into using various nicotine-related molecules on enhancing cognitive function. Having some difficulty with your verbal memory? Pop some nicotine, kind of thing. Wait till 2030, see what things are going to be like. Okay, I already discussed that. I'm on the pacifier patch. In alcohol use disorder, there are a number of medicines that act all in different ways, but the final common effect is to decrease craving to use, except for that antabuse. Antabuse is the oldest one of the list, and that was developed as a way to try to get people to drink less, because they were told in advance that if you're taking this pill on a daily basis and you expose yourself to some alcohol, you're going to develop a violent reaction. You're going to get extremely sick, you're going to start vomiting, you're going to feel pale and weak. Horrible reaction. And so the idea was, at the time, that if you know this is going to occur, you're going to lose your desire to drink. Well, it failed miserably because the individual quickly learned that if he wanted to drink, he just didn't take the pill that day. Sometimes doctors are stupid. The others have been shown to decrease craving in general for alcohol. Now, not everybody gets an effect from every medicine. Some people get an effect from some medicine and not from others, and now we're learning that it probably has to do with one's genetic makeup. I'm going to introduce a new type of receptor for you because it's going to go into the next slide as well, and that's that mu-opioid receptor. You remember one of the first questions I asked you. The mu-opioid receptor. Which one is an antagonist at the mu-opioid receptor? That receptor is the one that the opiates attach to, bind to, right? when you have severe pain and you take a Percocet, that oxycodone in that Percocet binds to that mu opioid receptor and you feel pain relief. That's the way it works. It turns out that there are many variations of that mu opioid receptor in each of us. Some of those receptors are more likely to bind tightly to any opioid. That's the person who's probably vulnerable to developing opioid use disorder or addiction. That's the person who develops euphoria when first becoming exposed to that opiate. You know, a very common scenario that we hear from our patients coming in for opioid use disorder. Their life seemed to be going along fairly well, healthy way, developing healthy relationships, get a job, being independent, taking care of themselves. They break their arm. Now, for the first time ever, they're prescribed appropriately a pain medicine. Oh my God, I want more of that. Typical reaction. For that person who has the vulnerability and never knew it, had made it this far in life, Nathan, welcome. So nice to see you again. Come on in. David, I see you back there. Up until this point in their life, they had no idea they've been carrying this vulnerability to developing addiction if they ever became exposed to an opiate. And by the way, you see where this is going. You can bet that we are going to have genetic testing in the future. So we can identify and tell you your child has a vulnerability to developing opioid use disorder. So we're going to take special precautions when he ever becomes exposed to that pain pill. We're going to tell you what to do. This is the way that unknowing person finds out, breaking an arm. And then a sequence of events occurs, the life falls apart within months, they're in our facility. So that opioid mu opioid receptor, turns out that gets stimulated by alcohol to release dopamine in the nucleus accumbens and develop the euphoria. Suppose we block it, block that receptor. So when the substance is there, the opioid is there, or the alcohol is there, trying to stimulate it, there's nothing. You can't do anything. It's like trying to put a car in a parking space that's already occupied. Can't happen. Block it. That's what naltrexone does. It blocks that mu opioid receptor, therefore decreasing the craving for alcohol. And by the way, it also decreases craving for opioids. If the patient with opioid use disorder is on naltrexone, shoots up heroin, nothing happens. A study showing the effect.
The problem is here, we've got the trajectory going in the opposite direction. So 2014, which is the last year that we have accurate data for, you see an enormous ongoing spike in the number of people who are using opioids in ways that are unhealthy, and you're seeing a significant rise in the number of people who are being killed. My administration, without congressional action, has taken a number of steps, and I know that you've heard from some of our administration here today about, for example, providing $100 million to community health centers so that people have more access to treatment. Concentrating on physician education in terms of how they prescribe painkillers to prevent abuse, making sure that the treatment, medication-assisted treatment programs are more widely available to more people, making sure that the, not antidote, but at least means of preventing people, once they have overdosed, from actually dying, is being carried by EMTs. So we're taking a number of steps, but frankly, we're still under-resourced. I think the public doesn't fully appreciate yet the scope of the problem. My hope is that when I show up, usually the cameras do too, and it helps to provide us a greater spotlight for how we can work together to solve this problem.
Opioid use disorder. Growing. Worsening every week, actually. The thinking is that doctors probably have played a role in this epidemic. Even in my career, I remember being in medical school when we'd have these patients come in and they were known to be heroin addicts, and they would develop some type of medical problem that truly required pain medicine. So they'd be given pain medicine, and what do they want? More, more, more. How much do you give them? And the tendency at the time was to withhold it. Not completely, but to probably give less than they really needed. We learned that that was probably not the best practice. It was better to give them more. Treat the pain. Although it's hard to know exactly how much, because their illness is driving the pain, which requires the medicine, but their addiction is driving the need to increase the medicine. Very, very difficult clinical situation. It all resulted in lots of changes in the field of medicine, including one promulgated by Joint Commission, which accredits healthcare facilities. In fact, we're about to undergo our first audit next month for Joint Commission accreditation. And they talk about the fourth vital sign, vital signs: respiration, heart rate, pulse, blood pressure rather. The fourth being pain. Nurses and doctors must ask, do you have pain? And if so, how much? Because we have to treat it. Now, that started a number of years ago, but it led to a tremendous increase in the number of prescribed opioids. Nobody predicted what it was going to result in, which is now this epidemic of opioid use disorder. I've been talking with you about people having a vulnerability to developing addiction if they ever become exposed to the substance. So what we didn't realize we were doing is that we were making more and more people exposed to the substance. And they are now learning that they have the vulnerability, but it's too late because they've developed this. And now we're starting to move back in the other direction. There was a major medical paper published recently by the CDC, now recommending that no doctor prescribe more than a few days' worth of opioids for any individual person. And you have to really be able to give a strong medical argument for prescribing any more than that. So, what do we do about treatment? In addition to all the psychotherapeutic modalities that I'm going to talk about a little later, we start with medicines. Now, there are a couple of stages, because if someone has become dependent on opioids, when you stop it abruptly, they develop this full-blown opioid withdrawal, which is extremely uncomfortable, and not one person in the room could tolerate that for more than a few minutes. Horrible retching, sweats, diarrhea, pain throughout the body. Terrible. Methadone is a full opioid agonist. Remember that mu opioid receptor. So any either illicit substance, opioid substance, or a prescribed opioid will stimulate that receptor, right? So as soon as it comes into the body, it occupies that parking space, leading to those effects: pain relief, decreased anxiety, euphoria, etc. Now, if you can stimulate that same receptor with an opioid that we can control, methadone, then we prevent the withdrawal. And so when someone goes into a detoxification program, in the past, the common practice was to simply give them enough methadone to prevent that withdrawal, and then taper off the methadone over the course of a week or so that they haven't experienced an abrupt change in their brain, and so they don't experience the withdrawal, and now go into rehabilitation. Well, that practice failed miserably. Those people all relapse. In addition to which, well, let me restart that. The thought was then to just maintain the individual on methadone for a number of reasons. At the time, heroin was the most commonly used opioid, and of course, it's not free. So to buy the heroin, the individual would start breaking the laws, robbing, stealing, selling your grandmother's jewelry, right? Doing all sorts of terrible things to get the heroin, and then injecting with dirty needles, causing an increase in hepatitis C and HIV. And so the idea was reduce harm by providing that full agonist opioid, methadone. It didn't really lead to improvement in the brain, though. You know, those people often had that call it an addict mentality, that need to manipulate, lie, steal, cheat. Didn't seem to improve cognitive function, empathy, judgment. And then we heard about buprenorphine. Buprenorphine was going to be different because it's not a full agonist at that mu opioid receptor. It's a partial agonist. So what's the big deal? Well, it turns out there's a huge difference between a partial agonist and a full agonist. The partial agonist can stimulate that receptor just enough to prevent withdrawal and make the individual feel tremendous craving, but not enough to create euphoria in most individuals. So it seemed to create just the right balance. We should be able to just provide this for a week, 10 days maybe, get the person off of it and send him on his way. That was the thinking in 2002 when the first small group of us in this country were provided with a special license that would allow us to prescribe it. You see, that's the other thing about methadone. It requires that it can only be dispensed by federally regulated clinics, and that the individual patient has to go there on a daily basis to get the dose. So this was another advantage to buprenorphine, the idea that doctors in their offices could actually prescribe it for a month at a time, making it much more convenient for the individual if they were going to stay on it. But we didn't think they would need to. They were going to tolerate this detox nicely and get on with their lives. We were wrong. Over the next couple of years after 2002, when we first started prescribing it, and attending meetings around the country, sharing experiences with each other, everyone was saying, you know, my patients are relapsing. This didn't work. I had them on buprenorphine for a week or two and tapered it off, and it just didn't work. They went back to using. So then people who do research were starting to create studies looking at what was going on, and in fact, they confirmed that most people were relapsing. So then the idea was, well, maybe they just need a longer period of time on this buprenorphine. How about 2 weeks, 4 weeks, 8 weeks, and now up to more than 5 years. Multiple groups doing ongoing studies. The studies are blossoming, actually, trying to understand what the recommended treatment length should be, et cetera, for in different clinical situations, different patients. And I want to show you an example of a study. And by the way, for the last family weekend, I put this slide up. In the United States, overdoses from heroin and prescribed opioids kill 68 people every day. 2 days ago, I read that it jumped to 78 people every day in just the last 2 months.
Yes, I just have a quick question. Sorry to interrupt.
No, please.
Where would the harm reduction type programs fall with the medication, but does it not? Because I was told that they were trying some new stuff up north where they were not trying to, I would say, cure the addiction. What they were trying to do was keep the person healthy and keep them in line so they're not creating crimes and all this kind of stuff. I guess needle sharing goes in that harm reduction part. So does the medication also go in that category?
Yes, with regard to methadone, using it as a maintenance medicine. And by the way, I'm glad you mentioned this because there are a number of needle exchange programs in the country. Very controversial practice. You know? Maintaining the heroin use. Use a needle, go to the clinic, hand it in, get a fresh needle. It has been shown to markedly decrease the risk of transmitting both hepatitis C and HIV. Does absolutely nothing for helping the individual's addiction. And that's the difference, and this is what I'm going to talk about. This is an example of a study. Now, let me tell you, I hope you know this, that when you go to your doctor for the treatment of anything, you hope that he has read all of the studies involving the treatment of that illness. And he is going to give you the recommendation based upon the knowledge that comes out of those studies. That is what good medical practice is. I didn't tell you yet. I told the students the other day. There is not one single medical illness that we treat today the way we did when I was in medical school. So imagine if I took my knowledge and experience in medical school, went through my residency, and now opened up practice, and continued to practice for the rest of my career the way we practiced when I was in medical school. My patients would get terrible treatment because we know so much more now. I can't imagine actually what the medical students have to study today in medical school, because the research in medicine expands exponentially. It's absolutely phenomenal. It's all I can do to just stay up with addiction psychiatry, let alone general psychiatry. The new studies every day help mold our practice, tell us what's been found to be effective, what's no longer effective. The studies that we thought revealed that this to be an effective treatment, they weren't really interpreted correctly. Let's go back and reinterpret them. Uh-oh, we were wrong. This is what the recommendation should have been. That kind of thing. That's what you want your doctor to do. Okay, so now you present with opioid use disorder. And you're initially put on buprenorphine to prevent withdrawal, initially primarily, but there are other reasons now that you're prescribed buprenorphine. And it's based on studies like this. So I told you we thought in 2002, when the handful of us were given that special DEA license, the end of 2002, to be able to prescribe buprenorphine, the studies had suggested that patients should tolerate being on it for a week to 10 days or so, coming off of it and doing well. And then later studies said, uh-oh, that wasn't right. Look at this one. 40 people were in this study, all adults. They received individual plus group therapy in addition to buprenorphine. This shows those people, there were 20 in each group, 20 who were on buprenorphine for 6 days versus those who remained on buprenorphine for 12 months. I'll interpret this for you. It shows you that the people who stayed on buprenorphine for 12 months, 75% of them remained in treatment. Of those who were on buprenorphine for 6 days, every one of them dropped out. That tells you something right away. People are more likely to stay in treatment, which, by the way, has been the one factor shown to be more powerful than any other for success in the treatment of addiction. Remaining in treatment. Seems pretty intuitively obvious, right? But as the students and residents, and actually some of you, know, our most difficult challenge on a daily basis is keeping someone in treatment. By the way, did any of you see my GroupMe message to Donna just before I started? Some of you remember pregnant Caitlin. You remember how resistant she was? That all changed beautifully. She stayed in treatment. She started to make progress. You saw initially at the last family weekend how resistant her mother was. She was so angry. But you all changed that. By the end of that Sunday, she was, or appeared to be, part of us. Got a message from Leland just a few hours ago. Caitlin is all packed. She's leaving with her mother. They've been planning this for weeks. Deceit. Mom teaching daughter, let's be deceitful. She's not likely to do well. Staying in treatment, most important factor. Okay, another study. One group of people, 4 weeks on buprenorphine, and then tapered over a week, or tapered over 4 weeks after that. Still, 85% relapse rate after 3 months. Okay, so I'm going to give you buprenorphine. I'm going to taper you over a week, or maybe even 4 weeks, and within 3 months, you have an 85% chance of relapsing. Isn't that great? All right. You have breast cancer, I'm going to give you chemotherapy, and it's going to make you sick to your stomach, you're going to lose your hair. And then after 3 months, there's an 85% chance that you're going to get breast cancer again. Would you accept that treatment? Not in a minute. I tend to be a little dramatic about these things because I got to tell you, the vast majority of treatment programs in South Florida practice that way. 1 week detox, taper you off the buprenorphine. You've got to get off of it because you're not clean if you're on it. Blah, blah, blah. All this ignorance causing a couple of things. Relapse, death. But if you're a businessman, something all the more important. The revolving door. If I get you to relapse, I can get you to come back into detox again at $2,000 a day. They'll never admit that. Nobody asked the question. So how long should somebody stay on buprenorphine?
A year or two, or however long it takes. A year or two, or however long it takes.
However long it takes for what?
For them to stay in recovery.
Okay, you're very close. Remember I told you that each neuron has about 10,000 dendrites, and that in addiction, many, many are lost. Markedly decreased, interfering with communication. Those circuits are not working. That's when you see the outside evidence of the impaired judgment, impaired executive function, impaired mood regulation, impaired impulse control, right? You see all of those things in your loved one with addiction. Well, he has fewer dendrites. You can't really hold it against him, right? It's a neurologic illness. Now we have evidence that buprenorphine goes way beyond just preventing withdrawal. It decreases craving. Yeah, that's great. That's a good thing. Something much more important. It helps to repair the brain. We experience stress. There are a number of chemical reactions that go into place in our brain that drive certain circuits in the brain to then react to that stress. We hope we're going to do it in a healthy way. That's coping strategies, right? Learning healthy defense mechanisms, coping with stress in a healthy way. That person with addiction cannot, because that same system, it's called the stress response system, has become impaired. It ain't working. They experience stress and they're using. It's the only coping strategy they have taught themselves. Use. Simple. We have evidence now that buprenorphine actually repairs the stress response system of the brain. If for no other reason, isn't that reason enough to use it, to stay on it until that stress response system is completely repaired? Why withhold a medicine that's going to help fix the person's brain? Makes no sense to take them off in a week. None whatsoever. Not if you expect them to get well. Yet that's the most common practice. That dendrite that has gone down to about 3,000, the neuron that has gone down to about 3,000 dendrites now starts to sprout new ones, eventually getting back up to the 10,000. Reestablishing those connections in those circuits. Those brain functions are now working. Now, we don't have to do a brain biopsy to know that in our patients. We recognize it rather. Wow, your judgment is improved. Your mood regulation is improved. Your ability to control your impulses is improved, et cetera, et cetera, et cetera. They can't do any of that without an improved brain. Those connections are now better. Buprenorphine helps that process. Yes?
How long does it take?
Great question. So, what we see is that in the same way that I break my arm, you break your arm in exactly the same place, we will heal at different rates. For all kinds of factors, right? Different rates. It's no different in substance use disorder. We provide all of these multiple interventions. We're giving the buprenorphine. We're providing the various psychotherapies that I'm going to talk about in a minute. The environmental, it's called milieu therapy. Right? Treatment, the structure of treatment. All of these things are working together to get that brain healthy. And we're monitoring it. We're monitoring the cognitive function. We're monitoring all those other functions that I just named off. When we see that individual who, by all accounts, has a healthy brain, what's that look like? He's responsible, exercising good impulse control. He's making good choices. He's attending meetings on a regular basis. He has a sponsor. He's working the steps. He's developing a healthy support system. He has a great job that gives him pride in accomplishing tasks. All of those things that would make you say, he's a healthy guy. That's all evidence that that brain has gotten healthy again. So, we know that when someone has been using opioids, it turns off the natural opioid system in the brain. When they stop using opioids, what happens? There's withdrawal. It means the natural opioids are not working. But it's just a natural function of the brain to try to heal itself. You know, if you cut yourself and you don't do anything about it, it's going to heal on its own. A minor cut. But the point is that it does it on its own. When the brain suffers any kind of insult, right, it's damaged in any way, it's genetically programmed to try to repair itself. So all of the processes that we're doing are increasing the likelihood that that's going to happen. How fast? Well, we've identified that that person is a healthy guy. He's on buprenorphine. Has his opioid system gotten healthy? It's time to test the waters. He's on 16 milligrams of buprenorphine. Let's see if we can get away with 14 milligrams. Cut back a little bit. See if his own system is working well enough. How do we know? We don't measure it. other than to look at the expressions of those brain circuits, right? Are we starting to see any unhealthy choices? Are we starting to see that he's skipping a meeting too easily? Is he not calling his sponsor as regularly as he should? Is he beginning to be a little too irritable? Right? We're actually examining these circuits of his brain. We see no change whatsoever, time to decrease again, maybe a couple of weeks later, etc. Right down to, now we're down to 1 milligram. Make the decreases even smaller. Now we go to 3/4 of a milligram. Right now I have somebody on 1/8 of a milligram, started on 24 milligrams, doing beautifully. We're both afraid to stop it. From 24 all the way down to 1/8 of a milligram, he's demonstrated his brain is healthy. So we shouldn't be afraid. He should be able to come off of it right now. There's been no evidence whatsoever that he's lost any benefit whatsoever. You know? What we find is that whole process typically takes somewhere between 1 and 2 years. A year, year and a half. Unfortunately, sometimes we find that we get to low doses and they do start to experience craving, which, by the way, usually when they get to that point in the program, they're healthy enough to recognize subtle evidence of craving, so they'll bring it to our attention. Earlier in the program, when the patients are much more ill, they won't tell us. So the craving intensifies, and before we have a chance to nip things in the bud, they're acting on the craving already. They're out the door. You know? The healthier person recognizes the more subtle signs of craving. Brings it to our attention, we nip it in the bud more easily. So it varies. It may be, no, I'll give you an example. On average, the studies show that about 90% of people will relapse if they're only on the buprenorphine for about a week. They'll relapse 85 to 90% over 3 months, up to 90% over a year. 90% either way. That leaves 10%. That means there are 10% of people who develop opioid use disorder who tolerate being on buprenorphine for only a week or so. They come off of it, they do fine. They don't relapse. They stay healthy. What's different about their brains? Right? That's what we're learning. We don't know for sure yet. But it probably has something to do with that thing called resiliency. Remember the 17-year-old who had no cognitive deficits on hairspray? Right? So what I think is probably happening is, they've been using heroin, they stop, come into treatment, they're put on buprenorphine to prevent withdrawal. During that short period of time, during that week, their own natural opioid system is bouncing right back. Now when they're off the buprenorphine 8 days later, their natural opioid system is working. They have no craving, no desire. They want to get healthy. I think that's what's happening. They're lucky. They're lucky, but they only make up 10% of the population of opioid use disorder. So I think that the general practice has to be keep people on it as long as it takes for their brain to get very healthy, as evidenced by these particular brain circuits working, exercising, good judgment, executive function, impulse control, mood regulation, anxiety tolerance, the capacity to learn, use their memory, and be motivated by healthy things. Those things are established and you've got a healthy brain. Now, see if you can tolerate coming off of it. I think most people should be able to. That leaves some who may have done irreparable damage to their opioid system, which can happen. They were so vulnerable to the effects of opioids that not only did it bring about the changes in the brain that we call addiction, but have done such damage to those circuits that now with anything we do, we can't get them to be completely healthy again. We can get them improved, but not completely healthy again, and that person probably needs to stay on buprenorphine for a very long time, if not forever. Look, most of you probably know that if you become obese, the chances are extremely high that you develop type 2 diabetes. By the same token, if that happens and you lose all that weight, the chances are very high you are cured of your type 2 diabetes. Guess what? Some of those people don't get cured after losing all that weight. They still have it. They've done such damage, the obesity has done such damage to their ability to regulate their glucose that they can no longer do it. So another example of that vulnerable person remaining with that vulnerability versus the resilient person who develops the obesity, loses the weight, and is completely healthy. You know, there are bariatric surgeons, actually. You know, those are the people who do the stomach surgery for obesity. They actually talk about curing diabetes. They see the obese person with diabetes, they say, we can cure your diabetes. Perform the surgery, lose all the weight, diabetes is gone. In most, but not all. I think what we're going to see in opioid use disorder is a similar experience. Okay, what are the psychotherapies we use? A multitude of different types of psychotherapies have been shown by scientific research to be effective in a number of illnesses. We're going to be talking about addiction here. Cognitive behavioral therapy involves recognizing thought patterns. We all have thought patterns, and how they affect our emotions and therefore result in the actions we take in an attempt to regulate those emotions. We fall into patterns of actions that kind of follow this system. So the idea is to help that individual recognize those thoughts that are resulting in these behaviors. And maybe if we can slightly modify the thought patterns, then you recognize how now the emotions are regulated in a healthier way, and now different behaviors are acted upon. That's the general idea. It sounds relatively simple, but actually has a very powerful effect and has been shown to be extremely powerful in the treatment of addiction. We incorporate, by the way, the concepts from each of these various psychotherapies into all aspects of the treatment program. Tomorrow, for example, you may hear one of the therapists attempting to intervene with one of the patients. And actually, if I remember, I'll point out to you whether that particular statement that was just said or the question that was just asked by that therapist is using the concepts of CBT or contingency management or MET or family therapy, 12-step facilitation. Because you can identify that just about everything we say, whether it's myself or even the students or residents or the therapists, are all based upon these principles. In contingency management, this involves the fact that, as I mentioned, the addiction has hijacked the motivation reward system. We are all motivated to engage in behaviors that give us rewards. That's that ventral tegmentum nucleus accumbens system. We want to constantly stimulate the release of dopamine in our own nucleus accumbens, do things that give us pleasure. Well, because that system has been hijacked by addiction, when patients come into treatment, we want to re-hijack it back. Right? We want natural rewards now to provide that pleasure. We don't want the patient to feel that the only thing that can give him or her pleasure is the substance. So research has shown that this system of contingency management does just that. Now, the studies over the years have focused on using vouchers, for example, given to an individual who's coming in as an outpatient and able to show that his urine is negative for substance. When that would happen, he would be given a voucher, and when he had, there are various variations on this, but he might have to get a number of vouchers before he then has the opportunity to get something out of the clinic store, for example, providing a reward. So you begin to see that, he's thinking when he leaves the clinic, we're hoping that he's thinking, that between appointments, he's going to remember that he wants to earn that reward. So he's going to stay clean in order to come back and get that voucher. The principles turn out to be very powerful. We incorporate that into our program in such that we're constantly looking for what is motivating the patient, what is likely to motivate the patient. We want to provide rewards. We look for opportunities to do that all the time. If the patients are making healthy choices throughout community, then we will reward them with the opportunity to go to LA Fitness, for example, for a couple hours. But we're always listening and looking for what they want, because we want to be able to translate that into a reward. So it's starting to show them that, first of all, something other than the substance can give them pleasure. So we're actually getting that nucleus accumbens to have dopamine deposited in from the ventral tegmentum by something else. You're going to the gym. Wow, look at that stimulation of the release of dopamine. We don't say it to them that way, but that's what we know is happening in their brain. I say, ha-ha, addiction, we're getting it back, kind of thing. And of course, those rewards become more sophisticated as the patient responds to treatment. Now, for example, the patient gets to have dinner on family weekend with you. That's a much more sophisticated reward, but only if it has been earned. Now, they're putting the effort into earning it. So you see how things are changing? They're putting the effort into earning the ability to have dinner with you, rather than putting the effort into lying and manipulating to get the drug, to get that reward. We're changing the system. When I was in medical school, we had to determine whether a patient was motivated or not. If the patient wasn't motivated, move on. Don't waste your time. It was like height. Once you're 6'1", you're always 6'1". Over time, research has shown that that was all wrong. In fact, motivation is dynamic. We can take someone with very low levels of motivation and turn them into someone who's highly motivated. There are very specific ways of doing that, and we incorporate those practices all the time. In family therapy, of course, we have learned that the dynamics, the connections with you are so powerful that they cannot be ignored. By the way, is Evan's mom here? Evan's dad. Oh, that was the plan. It's a shame that his mom, I'm glad you're here, but it's a shame that his mom isn't here because she is so incredibly anxious. And we helped Evan today to recognize how her anxiety is an obstacle for him achieving recovery. And we're teaching him to help us to help her. He's open to it. You have such an effect on your loved ones in terms of whether they maintain the resistance to treatment, and we'll talk more about that tomorrow, or you're actually facilitating treatment. So we are constantly addressing these dynamics with you. And you'll see we do it very intensively tomorrow in community, but less intensively during the family calls throughout treatment, and also providing those support calls in GroupMe to all of you. Finally, 12-step facilitation. There's plenty of research now supporting the use of the 12-step program in recovery from addiction. That wasn't always the case. It's only the last few years that studies are starting to be completed showing its effectiveness. And so that's why we integrated it into our overall program. We utilized all of the principles of a 12-step program. And I'll show you some fascinating data that support that. 12-step facilitation itself is teaching the patients about the 12-step program, helping them to identify the the importance of working with the sponsor, what the 12 steps really mean. By the way, what they really mean is helping the individual get his character to be healthier. You know, has nothing to do with drugs or alcohol. It applies to everybody with a psychiatric syndrome. In fact, I'll go beyond that. It applies to every one of us. And so it's helping the patient to recognize the importance of that. Our community meeting. Hi, my name is Linda, and I also bought into all of that hope and change crap. The resistant patient, our favorite. All right, a little about AA, founded in 1935 by Bill Wilson and Dr. Robert Smith, also known as Bill W. and Dr. Bob. International mutual aid movement in many, many, many countries around the world. Its primary purpose is to encourage alcoholics to stay sober and help other alcoholics achieve sobriety. The 12-step program of spiritual and character development. In 1946, the 12 traditions were introduced to help AA strengthen and grow. There are more than 2 million members. 64% drop out in the first year. The big book shows the story of how more than 100 men have recovered from alcoholism. Now the principles, you'll hear of AA, NA, Cocaine Anonymous, etc. Goes on and on. But the principles all share something very much in common. And it's this sequential notion of changing character. You know, recognizing, first of all, that the individual with addiction, who, by the way, in active addiction thinks that the universe revolves around him, right? Your needs are to fulfill his needs, right? Pure narcissism. So recovery requires a change in perspective for him to gradually recognize that your needs are equally important in any relationship, right? It has to be equal. And everything that derives from that in terms of what true health and recovery really is.